So I just wanted to say, first and foremost, I'm Sonny Butler. I'm the Head of Service for Hospitals, Continuing Healthcare and Adult Financial Services. I've been in post for nearly 2 years, and I'm really pleased about my decision to come and work for East Sussex. It's been quite a journey, and just talking to some of my colleagues within the service, we've all been part of that journey of change, and with any type of change there comes opportunity, but also some challenges around how we implement that change, but also more importantly how we engage not only the staff that work within that service, but also the public that we are here to serve. And I'm really proud by all of our achievements so far in that we have continued to excel despite all of the number of issues, pressures and challenges that have come our way, and we remain standing. Some of us just about, and I can speak for myself for that, but we're really in a strong position in terms of our service delivery. And whilst this session focuses on the hospitals across East Sussex, I do have the privilege of being the head of service for the Continuing Healthcare team, which won't be a subject of discussion today, and also the Financial Services team, which I could go on for hours in terms of the journey we've been on and some of the achievements that we've made. So I'm not intended on going through the slides word for word, but what I wanted to achieve with the slides is that for anybody not working in the hospital service, I wanted you to get some insight into what we do on a daily basis, and also how we're configured as an operational structured team. The team are based across a number of sites. We undertake assessment, intervention and safeguarding work across 4 main sites, and those are the Conquest Hospital, the Eastbourne Hospital, Bexhill and Irvine units, also known as community hospitals, Maidstone and Tunbridge Wells hospitals, the Royal Sussex County Hospital, Princess Royal Hospital, Upfield, Crowborough and Lewis community hospitals. So we're spread quite widely in our county-wide team, and perhaps that's not everybody's perception of what we do in East Sussex across hospitals. So were there any surprises for anybody on that presentation? I can tell, but it's not. Maidstone, yes, exactly. So what we have a responsibility for, so if a patient is an ordinary resident of East Sussex and they attend, or as an inpatient as a result of that attendance, one of our neighbouring authority hospitals, East Sussex has a responsibility to facilitate that person's discharge plan. And we have colleagues here today, such as Jacob, who will work within our out-of-county team to support those discharges on behalf of East Sussex. So we're a wide-ranging team. We have approximately 77 staff within our service, within the hospital service, which is a large number. Lots of work, but also lots of opportunity as well within our service. And in terms of what we do, I just wanted to just go back to the basics so that I can just set out what the fundamentals are for what we do in the hospital service. So we provide an assessment service. We don't only support people who are inpatients who have been warded and requiring consultant-led care. We're also involved in avoidance and admission avoidance, within the acute trusts. So therefore we work within the A&E departments, also known as gateways, and we would support that person returning home without a need to be warded to an acute stay. So that's a really great success piece of work. There's lots of work involved within that. I'm really pleased with the team who do a sterling job at the hospital avoidance work. The other area I just wanted to focus on is around the work that we do, and we do this, and Danielle will talk about this, I'm sure, is around the immense emotion that's involved with supporting somebody through a hospital discharge. People have often come into hospital through an emergency. It's not necessarily elected care, and with that comes a huge amount of unknown. The person's had a life-changing incident that's resulted in them losing function, which means that they can't care for themselves. They came in with a level of mobility that they could walk, they could care for themselves, and as part of their discharge they find themselves with a life-changing event, and that is really, really difficult for us as in the social care world to process with them. And we're on that journey of change. There's often trauma involved. There is huge emotions from families, lots of concern around safety, lots of concerns around it happening again. So what happens if? And a lot of our conversation within patients and people who've attended A&Es about what we can do to get you back home. That's our ultimate aim. And we want to ensure wherever we can is support somebody to go back home. It's a life-changing event if they don't. So we do, where we can, support a person to return home. And that may not be immediately, but somebody may go to a temporary bed and then return home following a short stay of rehabilitated care, reablement, or a stay in one of our commissioned beds. We work within an MDT, and as part of that MDT approach, we work really hard at retaining our social work and social care identity. And that's really, really challenging in an environment that's not social care, working with professionals who are not social care professionals. We work with conflict, we work with challenging views, we work with differences of opinion, not only from the public but also from professionals as well. And I'm really pleased with the model that we're working in and operating with, which is about how we can empower each other as professionals to resist some of that challenge and some of that pressure and push back so that we can get the best for the client and the carer, because at that point in time they're not necessarily thinking as we would think logically because of everything that's gone on prior to that admission to hospital. There is a link to our service structure, so I've included that within the slides, and that's available on our intranet. So what's important to us, and again I just wanted to go back to the fundamentals of what we stand for, and underpinning all of our social care practice are some key legislations that we have to work to, and these legislative frameworks are really at the bedrock of everything we stand for in social care. And I'm just going to refer to them, which is the Care Act, which is our primary legislation, the Equalities Act, the Human Rights Act, the Mental Capacity Act, and finally but not least the Mental Health Act. All key frameworks that we have to comply with within social care, and a real skill within our social care workforce to be able to work interchangeably across those pieces of legislation, and all of those are intrinsically linked to how we support somebody to leave hospital or how we support them with an assessment to return home. There's lots of work we do around reflective practice, supervision. We have monthly forums where practitioners, and Danielle's been a few times, to bring clients that they're working on to a forum where management are present, so we can talk through the risks that staff, practitioners and managers are holding on the front line. It's been a really successful arrangement, and I hope that the staff in leaving that forum feel that they've got the support of management and the oversight. And we're really clear in how we manage risks. So if risks are too great, and despite our many efforts we can't reduce or mitigate the risk associated to that individual or others, it's about how we can provide strategies and support whilst leaning on our legal framework to enable that practitioner to manage that situation. Really tricky, and some of our cases can be complex, which often involve the court, which is a process that most of us now are becoming more and more familiar with, Danielle included, unfortunately. But that's the right thing to do. It's the right thing for the client. It's the right thing for the practitioner. The courts are there to support us in managing these situations in somebody's best interest. I just wanted to just talk to briefly around what we aim to do, and ultimately what we aim to do wherever we possibly can is make sure that our approach is inclusive and strengths-based. And in simple terms, that is about making sure that the client is at the forefront and the centre of our thinking. They need to feel empowered and controlled and have autonomy over their life. They know what's best for them. We don't always. So wherever possible, and applying where we need to, pieces of our legislation, we would work with that person to achieve the outcomes that they want to achieve. And some of those outcomes they want to achieve may be unrealistic, or they may present a level of risk that we feel was not manageable. But it's about how we use our skills, how we use our intervention, how we use our collective knowledge to support people to manage and live their lives the way that they choose to live. And it's not always easy. We don't always achieve the outcomes we would like for somebody, but where we don't, we have to reflect and we have to learn from those experiences. And we're all learning. It's an important aspect of what we do, because each situation is different, and that's because each person and each dynamic that we're dealing with, which could involve family and could involve the support network of that individual, such as friends, carers and advocates. And for us, it's really important that we're able to work with that individual to manage those risks associated with their daily living. There's a detailed offering. I'm not suggesting I go into this in any detail. It is included in the slides, but this will give you some further insight into what we do within the hospital service, and I hope answer some of the questions that you may have, but more than happy to take those questions afterwards. So on to the opportunities within our team. So we have a few opportunities within our team. So we have an operations manager that's vacant. We have a practice manager, a senior practitioner and a social worker, and finally a resource officer as well. Those are key roles within our social work function, so there are opportunities currently. I've included some links to the vacant posts that we have within the team, and we would welcome applications from anybody suitably qualified and experienced who feel they could meet the criteria that's set out within the person spec. So the opportunities are there and included within the slides. That very nicely leads me on to introducing Danielle and asking her to talk to her slide. So
Thank you.
You're welcome.
Hi everyone. Yeah, I'm a little bit nervous, I'm just going to say that now. So I'm not great at public speaking, but I will do my best. So I've been in the team since 2016. I started as a resource officer, and then recently got on the apprenticeship and qualified as a social worker back in September last year. So I'm still in my newly qualified year at the moment, but have the background as a resource officer. So at the moment, my role is primarily working on Pathway 3, which is our discharge to assess pathway, where people have left hospital, a decision has been made in hospital that they might not be safe to return home for any reason at that time, and that they need further assessment. So they go to a discharge to assess placement where I become involved and further assess them. So normally these cases are quite complex, and there's a reason why they haven't been able to return immediately home from hospital. So that is kind of one side of the team, but we also have the team that work primarily in the hospital assessing people on the wards, which I used to do before qualifying. So I think what I wanted to talk about was the different skills and attributes that I think are really needed in this role. Obviously, I think there's kind of general skills in social work that most people have, such as compassion. What Sonny was saying about people normally, if they're in hospital, something traumatic has happened, and I wrote down earlier when I was thinking about the different models that we use, that trauma-informed practice and crisis intervention are normally at the forefront of what we're doing. People have normally gone through some sort of trauma to end up where they are. So having compassion for the people and understanding that whatever's happening in their life right now is probably really affecting them. I put down about being adaptable, because I think that's really crucial in the team. I think any social work role, but our team changed so much, the pathways change, legislation changes, and I think just being adaptable and being able to move with that is key. But that's being resilient, because it is challenging. You know, you get challenged constantly by families, by the clients themselves, by different professionals that you're working with, and there is a lot of pressure, high pressured. But you do have a lot of support. What Sonny was saying earlier about the monthly meeting that's available to take any complex cases to, or safeguardings. But in my role, there's also a meeting every 2 weeks where you go along and discuss your cases and make sure that you're doing everything that you should be doing, really. I also put about having a positive mindset, just because I do think that, again, that's quite important to kind of keep going. You know, things can be pressured, and I think it's important to have that positive mindset. Problem solving skills. Obviously we do work within legislation, but also a lot of the time you're using problem solving skills to navigate the cases and work out kind of what to do next. And the ability to build relationships quickly. When I used to work on A&E, we had 12 hours before they were admitted into the hospital. So we had to try and turn around and get them safely discharged within that time frame. So we had to build rapport very quickly with the clients and try and assess them safely and get them home. And I also wrote a little bit about what makes our team different to other social work teams. I haven't worked in many social work teams, but I did do a placement in learning disability. And the one thing that I noticed when I went into learning disability was that I kept being told to slow down. Because you just work at a different pace in the hospital team, everything's quick, and you need to, it is a lot quicker, I think, than other teams within the council. I also wrote about the medical model versus social model, because I think that's quite important as well. I think working with our health professionals, we are coming from different perspectives, and the medical model is more about once that person's medically fit, their work is done, whereas ours is looking at more of a holistic view and looking at the environmental factors and social factors and doing a big kind of a holistic assessment of that person's needs. So that is what I wrote about the hospital team.
Very pleasing, thank you. Well done, Daniel. Well done, thank you. It was really good and really insightful. And just to say, Danielle was a success story for us in terms of growing your career in East Sussex, starting as a resource officer to now a qualified social worker, and has always been and continues to be a really well respected member of our hospital service. So really pleased that Danielle could do this today. And I just wanted to say Danielle's not the only practitioner who has grown their career within the hospital. We have a number of successes who have left the team, but also some that remain in the team as well. I'm really proud that they continue to feel that the hospital service is the service they want to practice within their role. So this is a final slide from me, and I was thinking about how I could sum up this presentation and what I could leave you with in terms of a parting gift. And quite often we don't always recognise the huge achievements that we make within our daily life, and how we support others to make those achievements in, as we've said before now, really challenging times, really challenging environments, and some really risky situations. And we often lose sight of the good. And in losing sight of the good, because we're managing crisis, as Danielle alluded to, we're managing urgencies, we're dealing with dysfunctional lives, which results in us needing to react quickly and immediately to manage some of those demands and risk. But this was a compliment that I received last month from a family member who had an experience and was supported by one of our social workers within our team. And I just wanted to share this. I'm happy to read it out, Bianca, if needed. Would it be helpful? Okay. So just to give some context, is that the social worker referred to here as Social Work A is a member of our team and works in the hospital service. And the compliment came from a relative of a client. And it said, "Good afternoon. I wanted to email to share my compliments on one of your social work team regarding Social Work A. Social Work A became involved with my mum at a time when she had fallen and was in hospital with a broken hip. She was due to be discharged and be assessed in a care home many miles away from family and friends under the NHS pathway. Social Work A quickly assessed the situation and provided timely support to mum, me and my family to enable her to be discharged to a local care home very close to family. She moved in on the 27th of March and has settled in really well. She is happy despite having progressive dementia and enjoying meeting people and making friends. She has visits almost daily from her family and neighbours. Without social work aid support, that meant to read, this wouldn't have been achievable. So a really lovely testament there. And if you think about the practitioner involved and what they worked with, they used Article 8 of the Human Rights Act in terms of right to family life, used that whole family approach to making sure that the person's needs, psychological, emotional needs, were at the very centre of their assessment and intervention. And yeah, it made a very pleasant read to receive that. We don't always receive compliments because most of what we do goes unnoticed, but when we do, actually, it's really touching. So I just wanted to end on that and just say thank you for your time today, and thank you for your diligence in listening to what we have to offer from the hospital service. We're exceptionally proud of what we do. If you are interested in coming to work for us, I know some of you already do, and we are a friendly team. We pride ourselves on our practice. We remain on that journey to change and raising and increasing our standards. And I feel that as practice is becoming as high as our expectations for people, which is only a good thing. I just wanted to thank as well Danielle for coming today and for showing and representing her team in the way that she did. I'm really proud that you did what you did, and without being patronising, you did a sterling job. I'm really pleased we're able to do this together. Thank you very much, and happy to take questions.